Good evening, friends. After a long gap of 7 months, we are again starting our monthly meeting of Ahmedabad Gut Club, and I am pleased to welcome you all to this meeting. Probably there is a bombardment of more and more webinars nationally and internationally. So everyone may be little over reacted to this webinar, but I think it is wise to have our own experience in the field of gastroenterology and share our experience so that we can improve the patient management as well as the interpersonal relationship also. Today, we have three speakers, luminaries, Dr. Chirag Shah, Dr. Pathik Parikh, and Dr. Ravi. I will request Dr. Chirag to start our meeting and the discussion. Um, we have about 15 minutes of discussion and followed by 5 or 7 minutes of question answer or your comments. You are always welcome to give your comments and share your experience also. Dr. Chirag, please. Dr. Chirag is a DM gastroenterologist, fellow. He is practicing at Ahmedabad at Mission Hospital, and he is attached to Sterling Hospital in Ahmedabad. Dr. Chirag, please.
Thank you, sir. So I'll share my screen. Can everybody see? So the study I have taken today is from the reputed journal GI Endoscopy. The article was published this year, last month. And this is very interesting study as I find, because we routinely do endoscopies in elderly patients. And the data of impact of age and sedation on cardiocerebrovascular adverse effects after diagnostic endoscopy was relatively unknown. So many a times when we have an adverse event, especially when it is a serious cardiovascular event, it is very difficult to explain to patients relative that how did this happen and do this really happen at other places. So slides are not.
Sir, just click on your slide.
Okay. So impacts of age on cardio-cerebrovascular adverse events after diagnostic GI endoscopy, a nationwide population-based study. This study was done in Republic of Korea, where there is a general insurance system and everybody is covered by the same insurance system. Whether he is treated in hospital, he is treated in a nursing home or a private setup, private clinic, all the patients have are enrolled in this data. So it's probably the widest coverage, including a lot of heterogeneity into the private practice and into the hospital practice. And the data covers almost real life scenario kind of situation. So incidence and risk factors of newly diagnosed cardiocerebrovascular events within 14 days after diagnostic endoscopies were identified. These patients had undergone endoscopy between January to December 2015, and there were 19,43,150 subjects. So very huge data. And in these patients, after exclusion criteria, adverse events occurred in approximately 2.23%, which is to me a huge number in 14 days. So the aim of this study was to study adverse event after diagnostic GI endoscopy, namely cardiac and cerebral adverse events and other arterial thromboembolism and pulmonary embolism, and to evaluate the impact of age and sedation on these unfavorable outcomes. They included the age group more than 40 years in this study. So from HERA database in 2015, they took 29 lakh patients, of which they excluded patients who were previously diagnosed and treated to have cardiocerebrovascular disease. That means those patients who had acute MI, ischemic heart disease, angina, cardiac dysrhythmias, cardiac arrest, hypertensive heart disease, hypertension, ischemic stroke, hemorrhagic stroke, TIA, ATE, pulmonary embolism, use of anticoagulant, use of antithrombolytic agents within last 12 months. So all these patients were excluded. Subjects not including this previously diagnosed and treated, after this it remained 24,62,000, of which again those patients who underwent therapeutic endoscopy were excluded. So ultimately the diagnostic endoscopy patients who were part of this study were 19,43,000 patients, of which CCD occurred within 14 days in following diagnostic endoscopy in a huge 43,000 patients, and other were uneventful. So as discussed, exclusion criteria were previous diagnosis of or treatment of CCD within 12 months before GI endoscopy. For individuals whom anticoagulation and antithrombolytic agents were prescribed, including oral administration of more than 30 days, or subcutaneous injection of more than 5 days, or IV administration more than once, were also excluded. And therapeutic endoscopy patients were also excluded. What was the primary outcome? So the primary outcome was newly diagnosed cardiocerebrovascular event, which was defined as hospitalization with a cardiocerebrovascular event at least once, or an outpatient visit or emergency department visit at least twice from the same day, from the day 0 after the diagnostic endoscopy. Then the cardiocerebrovascular events were divided into major and minor events. The major events were acute MI, cardiac arrest, ischemic stroke, hemorrhagic stroke, arterial thromboembolism, and pulmonary embolism. And minor were angina, cardiac dysrhythmias, hypertensive heart disease, hypotension, acute ischemic heart disease, and TIA. Those patients who had undergone multiple endoscopy, the last endoscopy was considered as day 0. And for those patients who had multiple cardiocerebrovascular events, the first cardiocerebrovascular event was considered as was reported. So we go to the results. If we compare the baseline characteristic of all these patients, they were almost similar. So total subjects were 19 lakh, of which around 10 lakh were upper GI scopy, and around 6-7 lakh were colonoscopy, and around 2.5 lakh were mixed endoscopy and colonoscopy. And the age group, healthcare institution type where they took treatment, here they included tertiary hospital, general hospital, standard hospital, and even private clinics also. Anyone has comment? So roles of and types of chronic diseases which were included were hypertension, diabetes, valvular heart disease, chronic pulmonary disease, and all were similar in both the groups. So procedure, everybody was same. Now the number of CCDs that were reported was 2.323%, of which the cardiac events were 35,000, which was the highest, 1.78%, and stroke and TIA were 0.4%. Acute arterial thromboembolism and pulmonary embolism were seen in 0.06% of patients. So EGD group overall had more than twofold higher incidence of cardiocerebrovascular adverse event than the colonoscopy, and the incidence rate of all types of CCD events, overall CCD, cardiac, stroke, TIA, and both in non-sedation and sedation wear group were highest within first 3 days, because probably these were procedure related, right? So if we see, this is typically the picture that cardiac adverse events are seen in 0 to 3 days, were the most commonly seen, and then in some patients 4 to 7 days, and some patients late 8 to 14 days, which may or may not be related, we are not sure. Again, for colonoscopy, similar trend. However, the cardiac events are more with the endoscopy and less with the colonoscopy. And with both its EGD and colon, it is also seen maximum in the first 3 days. With the stroke, again, we can see that the maximum events happened in first 3 days. So most procedure-related adverse events which were seen here were in first 3 days. Acute thrombotic events and pulmonary embolism, more commonly seen in EGD scopy or EGD with colonoscopy than colonoscopy alone. What was the age effect and what was the effect of other factors on the cardio-cerebrovascular event? So older the age, so they divided into two groups, 70 to 99 and 40 to 70. So if you compare with 40 to 70 age group, the events were 1.69 times more in this group. Sedation was associated with 1.12 odds ratio. However, the and the confidence interval was good. Men were more commonly seen with this adverse event. They were more commonly seen in private clinic. We can see the odds ratio, that is 2.29. Inpatient endoscopy has had the highest risk, as probably the patients were more sick. Hypertension, diabetes, valvular heart disease, hyperlipidemia, COPD, and renal disease had some contribution. On multivariate analysis, hypertension had gone away because that was not the major factor which was also significant in multivariate analysis. Sedation during endoscopy was significantly associated with cardiovascular events with an odds ratio of 1.14 and acute arterial thromboembolism or pulmonary embolism, but not with the stroke. And midazolam alone was, and use of midazolam propofol, and they also used sometimes long-acting benzodiazepines along with this, were significantly associated with the risk of cardio-cerebrovascular events. So in older age group as compared to the younger age group, it was more common. For EGD, the OR was 1.8, for colonoscopy it was 2.1, and for both endo and colonoscopy in one session, it was 1.72. When we talk about the effect of age, we can see here that the trend is higher in the 70 to 99 year age group, where the adverse event related to the procedure are more in both EGD colon and endocolon combination group, and it remains near normal in patients who are younger age group. What are the clinical factors associated with cardiac adverse event? And so here again we are talking about cardiac adverse events, and and we can see it was 1.5 times more common in elderly people. This was the reference, and this is 1.14 times more common. For stroke, it is 2 times more common. Here it is almost equal. For pulmonary embolism, it is 2.43 times more common, and here it is equal. So effect of sedation is not seen surprisingly in patients who had undergone only colonoscopy, but it is seen in patients who have gone endoscopy or endoscopy colonoscopy in combination. This is a surprising finding. Discussion. So sedation is effective for reducing anxiety and stress during diagnostic endoscopy, and that favorably influences the sedation on blood pressure and heart rate that could reduce MI or stroke or TIA. These were the previous studies. So what this study adds is that sedation still has an effect, and it can probably be considered as a risk factor for cardiac and pulmonary embolism like events in elderly patients. Maybe impairment in hepatic and renal clearance of sedative agents can prolong recovery, and maybe that is the cause why these patients have these late events up to 3 days and many times up to 14 days. So cardiorespiratory response to hypoxia and hypercarbia, which may develop during sedation, is delayed with age. So now we can have some comments from Dr. Patwari and Nilabhai on this.
And Chirag, very interesting. But can you have they discussed why it is more common with upper GI scopy and not
So
with colonoscopy? And because most of the times the sedation is little more during colonoscopy and less during upper GI scopy. So
so
is
they
it
are
not
saying
surprising?
that the airway compromise which happens during upper GI scopy is probably the cause for these patients having this cardio cerebrovascular events. So it was that is why it was seen in endoscopy. It was also seen in patients where endoscopy and colonoscopy combined were done in
Combined.
one session.
What do you
Airway.
So what are the
Airway.
practical implications of this study?
So the practical implications could be there was in literature search I found that in elderly when you oxygenate patients for 3 to 4 minutes before procedure.
I'm sorry, but can you stop sharing your screen so that everybody will be bigger? Yeah.
So when during literature search I found that there was one study which said that if you pre-oxygenate patients for 3 minutes, then you can reduce the hypoxic events and hypotensive events during the procedure. But that effect of that pre-oxygenation on long-term effects or post-endoscopy cardiocerebrovascular events is yet to be seen.
I
do
have
you
a
suggest?
question. Do we really see so much of cardio-cerebral event while we are doing a
No.
So I think it is classical of Western countries where they are not bothered about something happens to the patient. If something happens in our practice, we all are gone. So probably we are taking more precautions than these guys.
So
I think 2.3% is anyway much higher than
yeah,
expected actually.
absolutely. So I thought the same thing, and in fact, they had mentioned that in discussion also. But they had mentioned that probably these events, if the patient's procedures were done on OPD basis, can go unrecognized, and patient may end up with physicians where we may not be aware. This is a huge difference. Yeah, huge difference.
In our case, something happens, it is impossible that we will not be aware, even if they go home.
Not 3 days. Even after 3 weeks, there is a problem, then you will be called for.
I think why airway.
But this is very interesting. I think we can have a look at our data and we can just write something like that.
But do you suggest that this 3 minutes of oxygenation before doing a procedure may be helpful? Do you think that way? Because it is a very practical small suggestion. I think no harm in doing that.
Maybe yes, but again we have to check because we are actually doubting the data.
Anyway, very interesting. Thank you. If there is no other comment, Nilay, any other
You
comment
can
do
go
you
ahead
have?
with the next presentation. Sir.
Next presentation. Okay. I think next is Dr. Pathik Parikh, who is DM in gastroenterology with fellowship in hepatology. And at present, he is working as hepatologist at Zydus Hospital. Pathik, can you start your discussion? Yes.
Yes, sir. Am I audible now?
You are audible, Pathik.
Yes, sir. So I'll just proceed. So the topic that I'll be presenting today is on an article on advanced hepatocellular carcinoma treatment. So
You have to first do the slideshow.
So when we talk about the advanced HCC, it usually means BCLC class C, where it is portal invasion, extrahepatic spread with a preserved liver function of performance status of 1 or 2. And the recommended treatment is systemic therapy. So most patients present with unresectable disease in our practice and they have a poor prognosis. The treatment that are advised as of now are sorafenib and lenvatinib. and they are the first line systemic treatments for unresectable hepatocellular carcinoma. Now, immunotherapy is being now coming up in a big way. So what we need to understand is the PD-L1 and PD-1 inhibitors. So if we see a tumor cell, the normal interaction between a T cell receptor and antigen stimulates the T cell and causes active immunity. But however, there is immune tolerance created by binding of PD-L1 with PD-1, and that leads to inhibition of the T cell. Now, if we give some form of antibodies or some agents which can block the interaction between the PD-L1 and PD-1, then the interaction between the T cell and the tumor cell would be activated, and this would lead to tumor cell death. So the concept of immunotherapy is based on inhibiting this PD-1 or PD-L1. So for atezolizumab and bevacizumab, there was a phase 1 study carried out, and which was known as GO3040, and which concluded that longer survival with the combination of atezolizumab plus bevacizumab than atezolizumab alone in patients with unresectable HCC who were not previously treated with systemic therapy. So the topic that I'm going to present today is an NEJM published article on atezolizumab plus bevacizumab in unresectable hepatocellular carcinoma. So PD-1 inhibitor, they have promising clinical activity as second line treatment. They did not significantly improve overall survival as a single agent. And the reason they attributed was overexpression of VEGF, and that have been linked to the development and progression of liver cancer. But when anti-VEGF therapies were added to this, that reduced the VEGF mediated immunosuppression within the tumor and its microenvironment, and the combination turned out to be much more beneficial. So atezolizumab is a selective PD-L1 inhibitor, and it prevents interaction of PD-1 with PD-L1. While bevacizumab or Avastin, that we all know, is a monoclonal antibody that targets VEGF and inhibits the angiogenesis and tumor growth. So this study is known as IM-BRAVE 150. It is a global multi-center open label phase 3 randomized trial to determine the safety and efficacy of atezolizumab plus bevacizumab as compared with sorafenib in patients with unresectable hepatocellular carcinoma who had not been previously treated with systemic therapy. So basically those patients who were qualifying to be receiving sorafenib or lenvatinib were categorized to receive this therapy. The inclusion criteria was 18 years or older, locally advanced metastatic or unresectable hepatocellular carcinoma, diagnosis confirmed either by histology or according to the ASLD diagnosis guidelines, who should not have received any systemic therapy before. They should have measurable disease on imaging. They have non-curative therapy. Curative therapies are not possible in these patients. They are good performance status, good liver function with CTPA, and they have adequate hematological and organ function. Those having autoimmune disease, co-infection with hepatitis B or C, or untreated or incompletely treated esophageal or gastric varices were excluded. The reason for it is increased bleeding risk with bevacizumab, so they excluded patients with high-risk esophageal varices. The trial design was, there was 2:1 randomization, where atezolizumab and bevacizumab were used in twice as compared to sorafenib. Randomization was performed through an interactive voice response or web response system, and each of the randomization was further stratified by geographic region, macrovascular invasion or extrahepatic spread, baseline alpha fetoprotein by less than 400 or more than 400, and ECOG performance status of 0 or 1. The trial design and intervention, around 1200 milligrams of atezolizumab plus 15 mg per kg of bevacizumab was given every 3 weeks to these patients. Sorafenib group received 400 mg of sorafenib twice daily, that is 800, that is full dose of sorafenib. The assessment was made by CT or MR at baseline, then every 6 weeks until week 54, and then every 9 weeks thereafter. So after a year, they did it every 9 weeks. The endpoint was, co-primary endpoints were overall survival and progression-free survival. Secondary endpoints were objective response rate, duration of response, time to deterioration of quality of life, physical functioning, and role functioning. I have not gone into detail of statistical analysis, but a sample size of 480 was expected, targeting 312 deaths, so that the power of the study comes out to be 80. So coming to results, 501 patients at 111 sites worldwide in 17 countries were included. The study period was from March 15, 2018 to January 30, 2019. And the median duration of follow-up after treatment was 8.6 months. So this is the baseline characteristic of the patients receiving atezolizumab plus bevacizumab. There were 336 patients, while 165 patients received sorafenib. The median age was significantly higher as compared to the Indians that we see 64, 66. Mainly male predominant. Mainly is good performance status of ECOG 0. CTP mainly were CTP A5 239 out of 333 and A634. So all were CTP A. 276 or 80% were BCLC-C. AFP levels more than 480 was 400 was seen in nearly 40% of these patients. Macrovascular invasion was seen in 38% of patients, and extrahepatic spread was quite common. So more than 50% had actually extrahepatic spread. The varicose status, around 30% had varices either present or treated at the baseline. And hepatitis B was the most common etiology in nearly 50% of these patients. So when we look at the efficacy of this two regimen, so if you look at the 6-month survival, in atezolizumab group, there was 84% compared to 72% in the sorafenib group. The 12-month survival, 67 in the AB group compared to 54% in the sorafenib group. The mortality being 28% in the atezolizumab group compared to 39.4% in the sorafenib group. If you look at the disease progression or death, 58.6% in the AB group progressed as compared to 66%. The progression-free survival was significantly higher, 6.8 months in atezolizumab group compared to 4.3 months in the sorafenib group. And if we look at the progression-free survival at 6 months, that was higher as in the atezolizumab group as compared to the sorafenib group, 50%. So more than 50% in atezolizumab group had progression-free survival at 6 months. So just a diagrammatic representation of the primary endpoints, that if you look at the overall survival, it was significantly better in the atezolizumab bevacizumab group as compared to the sorafenib group, and overall survival at 6 months being 84 compared to 72. And same thing is progression free survival was much higher in the atezolizumab group as compared to the sorafenib. Looking at the secondary outcomes, they assessed according to the routine RECIST criteria for solid organ or HCC specific mRECIST criteria. And if you look at the complete response in the atezolizumab group, there was 5.5% compared to sorafenib, and partial response also being significantly higher. If we look at the progression of the disease, so 19% progressed on the disease while 24% progressed on the sorafenib group. So percentage of patients with duration of response lasting more than 6 months, it was 87% in the AB group versus 59% in the sorafenib group. And if we look at the quality of life, so median time to deterioration of quality of life was much longer with atezolizumab group as compared to the sorafenib group. Looking at the patient reported quality of life, 11.2 months was the deterioration time compared to 3.6 months with sorafenib, and physical functioning was median time to deterioration was 13.1 for the AB group compared to 4.9 with the sorafenib group. Coming to the safety profile, more than 98% in either group developed some or the other adverse events. But if you look at the severe events, grade 5 events, which were seen in 5% of the patients in either of the group, and severe adverse event were slightly higher in the atezolizumab group as compared to the sorafenib group, with more than 1/3 of the patients developing severe adverse event. adverse event requiring dose modification was seen in 50% of the group of atezolizumab, while more than 50% in the sorafenib group, and treatment discontinuation was 10 and 15% in sorafenib and atezolizumab group. So if we look at the adverse event in the chart form, the grade 3 and 4 were seen in 55% of the group in both the groups, and grade 5 in 5% of both the groups. Withdrawal from atezolizumab, bevacizumab because of side effects were seen in 7% of the patients. And if you look at the adverse event with incidence more than 10% in either group, you can see that the adverse events were much more with the atezolizumab group as compared to the sorafenib group, with hypertension being the major effect in patients with atezolizumab, bevacizumab, and fatigue and proteinuria being the second most common side effects when this combination is used. So they found out that the 2.5-month increase in the median progression-free survival with atezolizumab, bevacizumab is achieved, and 88% of the patients who had a response, which may be complete or partial, continue to have this response at 6 months. So if they respond, the response is quite sustained with atezolizumab, bevacizumab group. GI disorders were the most common reason for discontinuation of the atezolizumab group, as expected in patients with liver cancer and underlying cirrhosis. Upper GI bleeding, which is expected to worsen because of bevacizumab related bleeding deaths, it was seen in 7%, which is comparable to 4% in the sorafenib group. Looking at the limitations of the study, it was an open label, and in a response published in August, they have said that the median duration of follow-up of 8 months is significantly low as compared to other studies which have published, which have a median follow-up of at least 13 to 14 months. So 8-month follow-up is quite short follow-up for a person to take a call. They concluded the study saying that AB was associated with significantly better overall survival and progression-free survival outcomes than sorafenib in patients with advanced unresectable hepatocellular carcinoma, not previously treated with systemic therapy. Serious toxic effects were noted in 38% of the patients who received combination therapy. However, no new or unexpected toxic effects were observed, and the combination therapy also resulted in longer time to deterioration of patient-reported quality of life and functioning as compared to sorafenib. This is a diagrammatic representation of the abstract, where to summarize, 501 patients, the median survival with atezolizumab 6.8 months as compared to 4.3 months with sorafenib in an open label 3 trial. In a correspondence published in the same publication by Dr. Kelly, they said that it is the first successful combination regimen for HCC, and it should be considered as a new benchmark for the first-line therapy. Based on this phase 3 trial, on May 29, 2020, FDA approved this combination for unresectable hepatocellular carcinoma. And I was listening to Professor Masatoshi Kudo in an APASL meeting, and I had a privilege to work with him in the at least look at the response of atezolizumab when the patients were under his treatment. And he recommends that atezolizumab plus bevacizumab should now be considered as a first-line systemic therapy for hepatocellular carcinoma over lenvatinib and sorafenib. Just a package insert, it is available in the name of Tecentriq, 1200 milligrams to be given, which is to be followed by 15 mg per kg of bevacizumab on the same day every 3 weeks. And it is available as 60 mg per ml vial. Immune-related are the side effects which are mentioned. But if we look at the data published, the most common adverse events with Tecentriq in combination with bevacizumab in HCC were hypertension, fatigue, and proteinuria. I was just looking at the cost of this therapy available in India. So the cost of atezolizumab, a single would be 3 lakhs per vial, along with bevacizumab additional, which needs to be given every 3 weeks. Thank you.
Pratik, just stop sharing your screen.
Yes, sir.
Now I have a question. If you see the
Yes,
trial
sir.
was done only in childless cirrhotic. So how many childless cirrhosis with advanced HCC we see? And so in other sense, would you give it to patients with child B and C? C to forget it. There is no point in spending so much of money. But what about child B?
So the child B, I don't think that there is any recommendation. I think all systemic therapies are the recommendation is mainly for child A only. So if you look at lenvatinib, sorafenib, or this therapy, all recommendation are mainly for child B. 96 to 97% of the patients even in those trials, they used it for child CTP A only. And I think I had a patient who was also under the treatment of Patwari sir, where actually had a AFP of more than 1 lakh, had a portal vein thrombosis, but was CTPA. And I actually gave them an option of atezolizumab, but they didn't proceed with that, sir.
Your mistake was you spoke to the patient directly. You should have talked to Dr. Patwari, and then patient would have taken it.
No. Nilay, the patient was 84 years old with
Yes.
some renal insufficiency. And in fact, within few months, we lost him also with one or the other complications. So I think it was not a right choice. The patient was not right for it, actually. Otherwise,
Yes.
it can be given.
But Pathik, you did not answer. Would you give it in child B or not?
Sir, no. This would be, finally this regimen is the reason of presenting this article was we write, whenever we come across this patient, we directly write sorafenib or lenvatinib. We just need to be aware that oncologists, and if they are affording, and CTPA, probably we can take help from our oncology friends in this case.
I don't know, but most of the oncologists also, they don't write sorafenib with the right dose. They give 200 BD. And I don't know, it is more of a placebo than the right medication. And most of the times when you write 400 BD, patients have so much
also giving
sensitivity and side
tamoxifen.
effect that they stop it.
So many side effects, actually. Sorafenib, so many side effects. Practically, I don't think you can give 400 BD for a longer time.
But I think if we have a CTPA cirrhosis, probably with a metastatic disease or a main portal vein invasion, we may consider this. We just need to keep in mind that this is a therapy which is now FDA approved and may be considered, though most of our patients would still prefer to take lenvatinib rather than go for a chemotherapy, which is quite expensive and with just 2 months of prolonged survival. But at least we need to be aware of it, and sometimes
what is your
we may
personal
find a
experience
patient
with
who
lenvatinib?
Sir, lenvatinib, the experience over here, I have just seen 2 or 3 patients who have survived more than a year and with a completely disappearance of disease on lenvatinib. And in Japan, when I was there, so there the lenvatinib response was so good that there were patients at the end of 3 years taking lenvatinib with absolutely zero disease remaining. So they used to pick up on a contrast and an ultrasound, come for a contrast and an ultrasound every 3 months, and they were not even you can actually see the vessel shrinking on lenvatinib in those.
So would they give any local therapy or just give them lenvatinib? Even if local therapy.
Sir, there is this Professor Masatoshi prefers lentase therapy. So he says that if the HCC tumor burden or a tumor is more than 6 centimeter, so the response to TACE is unlikely to be sufficient. So what they recommend is 3 months you give lenvatinib and then do a TACE.
See, TACE, anything which is more than 3 centimeter, it is not a curative thing. It is more of a palliative. So,
but even for a palliative therapy, TACE followed by when multiple TACE session followed by failure and then leading to systemic chemotherapy, that is what we ideally believe. But what they recommend is you should consider lenvatinib first. You give it for 3 months, shrink the vascular supply, shrink the tumor, and then you do a single session of TACE. The response is better and the overall survival is better. I actually deleted that slide because it was not a part of this presentation. I had put it, but this is what they recommended. We should not hurry up doing in TACE. We should actually give them systemic therapy for a short period of time and then proceed for TACE if the tumor burden is quite high. And we know that the response is not going to be good.
I think now, yes, sir.
Your logic is very.
Yeah, can we go on to the third talk? Otherwise, we'll be talking till tomorrow.
Yeah. Yes, right. I think I will invite Dr. Ravi, who is a young gastroenterologist. He has done DNB from Global Hospital Chennai, and he has joined as a young consultant at Ansh Clinic. Ravi, can you share and discuss your case?
Sure, sir. Good evening to everyone. Today I am going to present my one of our case. Is it visible?
Yes, yes, it is visible.
Yes. Uh, I'm going to present one case of acute viral hepatitis. Actually, my patient was a 35-year-old female from Chota Udaipur, admitted with the chief complaint of fever, which is a mild grade intermittent since last 10 days, nausea, vomiting, and loss of appetite, and yellowish discoloration of eyes and urine for last 7 days, with mild right hypochondriac upper abdominal pain. There was no history of any alcohol, native medication, or other medications. There was no history of blood transfusion or operation, or no history of altered sensorium, abdomen distension, or GI bleed. In past history, no history of patient was not hypertensive, non-diabetic, no other major illness. And in personal history, no history of any addiction. On examination, on admission, patient was conscious oriented. She was deeply icteric with bilateral minimal pedal edema and no pallor, no palpable lymph nodes. On vital, temperature on admission was 100 degree Fahrenheit with pulse rate of 110 per minute, blood pressure 110 by 70, and O2 saturation on room air is 95%. On abdominal examination, mild right hypochondriac tenderness with 3 centimeter hepatomegaly, no free fluid. RS, CVS, and CNS examinations were normal. Uh, Initial primary blood test, HB was 10.7 gram, total count 9,700 with 50% lymphocyte, platelet count 1.3 lakh, and peripheral smear shows hypochromic microcytic. Uh, Creatine was 0.7, and total bilirubin was 7, direct was 6.9, SGPT 735, SGOT 963. Ag ratio was altered. PTINR was 1.65. Uh, According to her clinical presentation, we proceed with the initial viral markers. HBsAg, NT-HCV, IgM, HAV, HEV, all are negative. Even dengue IgM NS1 also negative. USG abdomen shows uh, pericholecystic edema with minimal free fluid and few enlarged periportal lymph nodes. X-ray chest was normal. So patient was started on empirical antibiotic with IV fluid and other supporting medication. And we are also searching for other etiologies, and we ask for infectious disease specialist opinion. And we evaluated her for other etiology like HIV, brucella, EBV antibody, HSV, and other autoimmune diseases. On day 5th, patient gradually developed tachypnea and developed hypoxia, and saturation was 80 on room air. Chest X-ray suggestive of some congestive changes. 2D echo was normal. ABG shows CO2 washout with hypoxia. D-dimer ferritin was high, and in this era we need to check for COVID-19 in this condition, so that was negative. Uh, she was shifted to ICU and managed with the diuretics and IV fluid restrictions. At the same time, patient also developed HB fall from the 10.7 to 7 gram, and the PTINR was more than 20 seconds. There was no history of hematemesis, melena, hematuria, or hemoptysis at the same time. Uh, on the same day, we received all other reports for other etiological agent we sent for. So HIV, brucellosis, HSV, autoimmune, all markers are negative, but EBV came positive, Epstein-Barr virus, and it is also IgM virus-specific capsid antigen antibody was positive. So that is more specific for EBV. So according to ID specialist, opinion, we started on dexamethasone and acyclovir. And for altered PTI, we also gave vitamin K and FFP. And drastically, patients improved within next 3 days, and we also discharged the same patient in next 3 days. And these are the other investigations. Patient was admitted from 12 to 21. That major event, and patient was shifted to ICU on 18th. So you can see that initial patient was worsening, but after the starting on the dexamethasone and acyclovir, patient improves very well, and all parameters are improved gradually. And these are all other investigations. And basically, EBV hepatitis is consists only 1% or less than 1% of all adult acute viral hepatitis, and is more severe in adult when compared to pediatric age group. And Epstein-Barr virus is also associated with other diseases, Burkitt's lymphoma, PTLD, and Hodgkin's disease, and oral hairy leukopenia. There are most of the in literature search, there are many case reports are there. There is no large scale data available for this. There in one Korean journal there are 2 case reports, and in other gastroenterology in 1 case report. And EBV is also one of the rare causes of acute liver failure. And EBV also is a cause for transient hepatopulmonary syndrome. Thank you. So actually, I want to convey the message that this is one of the etiology other than ABCDE. Thank you. Hello. Hello.
Yeah. And am I on? Sir?
Yes. Yes.
Dr. Patwari, you have to start your audio. Your audio is muted.
Oh,
Yeah.
now it is okay.
Right.
How did you suspect EB virus in an adult, or you just randomly sent all the investigations?
Actually, sir, HSV, EBV are the one of the other viruses that can cause acute hepatitis. That's why ID specialists suggest us to send this virus marker. That's why we send, sir.
Normally, sir, EBV, whatever EBV hepatitis, I have seen EBV hepatitis, HSV hepatitis, brucella hepatitis. They have some systemic other involvement. So EBV patient usually will have neck glands. Their SGOT is more than SGPT. So when we have more SGOT than SGPT, many a times it is non-hepatotropic virus or underlying chronic liver disease or alcoholic, or that we know. So non-hepatotropic virus, see, whatever EBV I have picked up in past is because they have either history of sore throat or they have neck glands. And when they have those things, I always think about EBV. Last EBV I saw in lockdown 2 months back, young patient from a good family, same history, hepatitis. So he was referred to me, but he had throat pain history and he had neck glands. And then I did EBV test and it came positive.
I have seen 2 patients, both have sore throat and neck glands. But otherwise, it is very difficult to
HSV,
suspect.
same way, HSV is always a systemic disease. So whenever we get HSV hepatitis, most of the times it's a systemic involvement.
So both the patients that you saw in OPD basis were treated with acyclovir?
Yes, I agree. Yes.
Because I have one patient who is seropositive with, right now, just today I saw with the IgM ABV positive with cholestatic liver pattern. Means SGOT, SGPT. And other workup one I was doing, the CMV, HSV and EBV IgM is positive. So it is just a OPD patient and routine investigation.
What did you, I'm sorry, you said CM, something about CMV?
The patient is seropositive with cholestatic pattern of liver enzymes, And I asked for CMV, HSV, EBV before jumping to liver biopsy. Patient pattern is
But are you
OT.
sure it was HSV? Because HSV usually will cause hepatitis, not the cholestatic pattern.
Yani OTPT and alkaline phosphatase elevation in he is already on multiple medicines. So he just ordered an investigation. I was planning for liver biopsy. So IgM EBV is positive. So today my confusion was, should I treat with acyclovir and or I jump to liver biopsy? I'm planning liver biopsy in next week.
Wait for liver biopsy in this patient.
Okay.
Wait for some time. That is what I would do.
So EBV does present with only acute or do it have a chronic presentation also?
I am
Anybody
not
has an
aware of it. You must have gone through it. No? Did you read about it?
Today only I opened. I asked Pathik there, but he said there is no treatment. I took 2-3 days back. I also got with him.
In literature also it's mentioned that only acyclovir is suppresses its replication, but it's not a proven treatment.
Okay.
Yeah, I think it was an excellent case. All the three presentations were very good, and we are starting afresh after so much time, after so many months. And I think with Dr. Vatwari, we actually thank you guys, all the young guys, for taking this initiative and starting some academic activity. In fact, we are so bored and we are so tired of webinars, but this was a refreshing change, and we look forward to many more webinars of our own family. Dr. Patwari, can you conclude it?
No, I agree with you. In fact, and thank you all the speakers, Nilay, and all the delegates who have joined us, and for your positive comments also. So I think it is interesting to have our own experience, our own colleagues discussing their experience and their literature. And let us meet, I think, every month or 2 months, so that let us refresh our knowledge and update also. Thank you all for this evening meeting. This is more comfortable also. Actually, the web meeting, the late evening, I think it is more convenient for all of us. So if you all agree, then we'll have Thursday 9 to 10 meetings in future also. Thank
Agree.
you all.
Actually, we should entirely shift to this.
Yeah, I agree actually. But see, this is more convenient. But at the same time, there is no personal touch actually. You meet friends and people. That is always better actually. But I think at the present circumstances, this is the best way of meeting and having the scientific updates. Thank you all.
Thank you all.
Thank you, sir.
Thank you, sir.
Thank you. Thank you.